Yeah,
Good
you can.
evening, everyone. I'm Dr. Astha, a second year PG at SN Chennai. Very warm welcome to our 21st session of our Powwow meetings. This month's discussion is based on Retina. I now invite Dr. Subneshwari Madam to take over as moderator and introduce our esteemed panelists. Over to you, ma'am.
Thank you, Asta, for the very nice warm up. Good evening, all ladies and gentlemen, and dear friends and teachers. We are here to begin our Powwow, the 21st Powwow year. And this meeting is like a very informal meeting among friends, seniors, juniors, and teachers, so that we kind of stay connected. And this month is going to be Retina, and today's presenter is going to be Dr. Sudipta Das, who is a very well-known senior consultant vitreoretinal services from Netralayam, Shankar Netra. I mean, he is from Kolkata, so I always feel he's more connected with Shankar Netralayam than anything else. Yeah. So welcome you, Dr. Sudipta. He's going to be presenting interesting case. And this power is like what we do is it's practical tips, more of practical tips, and then we have discussions about how we can, learn better or rather serve our patients better with a good understanding. So, with that, I will invite our panelist, Dr. Muna Bende, ma'am, who has been all our teachers, so all of us know ma'am very well, and she is currently the head of Department of Vitreoretinal Services in Shankar Netralaya. Ma'am, welcome you to for the this power webinar, and we have Dr. Manvi Shindal, my senior, and she's been a good guide for me when I was doing my fellowship. And she is currently the senior consultant and the head of the department of Arvind Eye Hospital, Pondicherry. And she's a great friend of mine. So, welcome you, Dr. Manvi, for this webinar here today. And I would like to welcome Dr. Lala Kundava, who's my very good friend. And and in spite of her busy schedule, she's decided to join us today. And Lala Akundava is like, she's done her PhD, and apparently her PhD is also on epiretinal membrane. So she is going to be more focused into that, and she probably is going to offer more insights to all of us. Welcome, Dr. Lala here.
Thank you so much,
Yeah.
Subneshwari, for introduction. But that is very rare case. That is not actually my PhD, but it's okay. It's some part of PhD. But that is very rare case. I even read several days in PubMed. It's very rare case. What he will present, Dr. Sudipta.
So I'll now welcome Dr. Anupama, who is my great friend, and actually Dr. Anupama is the one who taught me how to do laser. So whatever I am doing laser is currently my first laser she has supervised. So Dr. Anupama Bapal, she's a medical retina consultant. She's currently in Enapoya Medical College, and she has her own private practice as well. Welcome, Dr. Anupama.
Yeah.
And
thank you, Subneshwari.
Yeah. So we have Dr. Muhammad Arif, who is from Jeddah, and he is a senior consultant vitreoretinal services, and he is also in a medical college setup, so where he has a lot of postgraduates. So this is the first power where I think Arif is joining as a panelist, and we all know him as a very sincere, hard-working person. So welcome, Arif, for this webinar today. So now, so it's nice to have all of you here, and I'm sure we're going to have very good discussions. So with that, I will request Dr. Sudipta Das to begin the presentation and share his slides.
Shall I start? Yes.
Sudipta, you can start.
Yeah. So probably you have to just, because it's there in animation, so maybe just. So we start with this patient of 51-year-old hypertensive male, so who was actually a photographer by profession, has a diminished of vision and distortion of vision in the left eye for the last 3 months. This was the left eye, and he was not known to have any other comorbidities. So these are the vision: 6, 9, and 6 in the right eye, 6, 12, and 8 in the left eye. The Amsler split chart revealed metamorphosia in the left eye. Slit lamp examination of anterior segment was unremarkable. IOP was normal, and this was the right eye fundus photograph. You can see there is an absence of mobile reflex in the left eye. No. Before this, So there was an orangish lesion, there was a PED, there was RP alterations in the central macula of the left eye. And this was the OCT, structural OCT, as well as the OCT angiography. You can see a structural OCT, there was subretinal fluid, there was double layer sign, there was a PED, there was a slight amount of knots there. And in the OCT angiography, there was a flow in the outer retina. The other choreo capillaries and everything was unremarkable. So the treatment part, so suspecting to the case of polypoidal choroidal vasculopathy, I'll tell put into angiography because he had a taste dose allergy previously. In many of the institutions, he was not very keen to do angiography. So anti-VEGF injection of ranibizumab was advised in the left eye 2 times at 6 weeks interval. And this was the subsequent OCT. On the right side, you can see there was a flattening of the PED. BLS was also quite flattened. SRF was not there. Foveal contour also was quite normal. So left eye has a complete resolution of subretinal fluid following the injection. So OCT angiography after 2 injections of anti-VEGF, left eye maintained a stable vision of 6 and 6 even in the second year for this patient in the left eye. So this was the OCT angiography later, and this was the structural OCT down. There was a very fresh amount of subretinal fluid. Patient was absolutely okay with that. So we followed up this patient for the left eye. The issue was that actually what I want to say about where is the ERM. So this is the right eye fundus photograph. You can see temporal to the disc. We can see parafoveal epiretinal membrane, and there you can appreciate the superficial neovascularization nasal to the fovea. Surprising fact, this patient was absolutely asymptomatic in the right eye. Who is a photographer? He was having complaints in the left eye distortion. The right eye with this fundus photograph, he was absolutely normal, and we could appreciate some amount of hypertensive changes in the right eye photograph, both eye. But this is quite obvious. We can see in the right eye. So this was the OCT angiography. So we can see there was hyperreflective layer on the surface of the retina. OCTA had increased flow signals in the superficial capillary plexus corresponding to the area of infraretinal neovascularization. The DCP, the outer retina, and the choreo capillaries remained unremarkable for this patient in the right eye. So the patient was kept under close observation for the right eye as he had no distortion or worsening of the vision. Patient was given an ambulatory chart to monitor. FA, as I told, was not done because this was a condition where we needed a fluorescein angiography to rule out a lot other things. But we kept watching this patient. So this was after 1 year. You can see the ERM still there, and this was the left eye. So fundus photograph also, you can see the neovascularization is still there. Maybe the visuals are not that obvious, but no treatment was given for the right eye, and patient was still asymptomatic in the right eye. Left eye actually, after resolution, he was doing well. He was going well with his profession. This was the vision 6/9 and 6 and 6/6 and 6 in the left eye. So coming to discussion, because a lot of things came into our mind that fibrovascular epiretinal membrane are a frequent complication, mostly seen in proliferative retinopathy and retinal vein occlusions. But there has been one report of a patient with Carson syndrome presenting with an ERM complicated by preretinal neovascularization. So in our patient, we hypothesized probably hypertensive changes leading to decreased retinal vascular perfusion, creating a favorable environment for secondary neovascularization of idiopathic ERM through VEGF upregulation. And histological immunohistochemical studies have revealed VEGF positive cells more in fibrovascular membranes, complicating PDR. This can also present in the relatively avascular PVR membranes. These have been reported. So this was going through literature. We thought that this was one report in AGO case reports where there was a vascularized ERM, and they have thought that probably is arising in the context of inner retinal ischemia. They have concluded that the PVD should be attached. In our case also there was no PVD. So there was no PVD. So it requires a scaffold for fibrovascular or fibroglal proliferation. And possible influencing factor, according to this study, they felt that probably there was an old perimacular branch RVO. Here, angiography would have helped for this patient. A congenital retinal anomaly. We didn't see any pigments in this patient, no RP components here. An age-related macular degeneration-related lesion, we didn't see any brucines, though there was a PCV, suspected PCV in the left eye, and it was treated with anti-VEGF. And neovascular and associated with telangiectasia, also we couldn't see any angiographic, OCT angiographic changes in the deep capillary plexus, so probably that also can be ruled out. FA leakage was treated in this patient. FA leakage was there in the vascularized ERM, and which was treated with injection anti-VEGF. There is one report in IGO, but they had a multimodal imaging of idiopathic florid vascularized epiretinal membrane, but they actually operated this patient because patient was symptomatic. And despite the advancement in macular surgeries, risk of intraoperative hemorrhages while peeling vascular ERMs is still high. Prior anti-VEGF in this patient, they have used anti-VEGF before the surgery, and though they couldn't reduce the intraoperative bleeding for this patient, which prompted the authors to use silicone oil as a tamponade, and completion of the ERM removal is mandatory to prevent recurrence. This can be ensured during the surgical procedure, and they have advised to have an intraoperative OCT, which is a better tool to diagnose intraoperative ERM removal. So to conclude, coexistence of idiopathic epiretinal membrane with intraretinal neovascularization is a rare entity. Multimodal imaging holds the key to help in differentiating the causative etiology. It can be an incidental, asymptomatic finding in the fellow eye, emphasizing the importance of bilateral evaluation and routine imaging in retinal cases, even when symptoms are unilateral. This case underscores the need for individualized patient monitoring, as atypical or concurrent pathologies like ERM with neovascularization and PCV may alter prognosis, treatment decisions, and follow-up strategies. Surgery can be deferred in asymptomatic patients, as we have seen in these cases, as the risk of intraocular hemorrhage is pretty high in all of these cases. These are my acknowledgements. I thank Dr. Mundi for giving few OCT angiographic photographs for this patient. Thank you so much for the patient hearing. Maybe we can have a discussion for this, because actually I was clueless when I saw the patient, so probably we need a feedback on this.
So that was a very nice case, Sudipta. So now I will request Dr. MPB ma'am.
Yeah, I'm still there. Next few
Yes,
minutes.
yes. That's why I thought I will ask take your comments about this patient before we start the other discussion.
Sudipta, thank you very much. Beautiful case, and I understand the challenges you had because of the lack of fluorescein angiogram. If it was a younger patient, then sometimes we think of toxocara, because toxocara can also cause a vascularized epiretinal membrane. Recently, I've operated on one patient, which
Okay.
later turned out to be toxic. So whenever someone tells you to do a diabetic patient for ERM removal, is actually flat vascular proliferation, which that is also one thing that we need to look at. Other than the rarer causes like hematomas and other lesions, I think it's important to recognize the vascular component before it causes any further problem. And I think it's nice that you did it. And also, if it's not causing any problem, you may choose just to leave it alone.
Okay. Yes,
But
ma'am.
very nice, yes, lots of food for thought. Thank you so much.
Thank you, ma'am.
Thank you, ma'am, for those nice comments. So now I will request Dr. Manvi. Uh, Manvi, in your experience, how often have you seen these kind of vascularized epiretinal membrane?
Yeah, actually, thanks for bringing up this case. It made me do some literature search and read up some stuff in the past 1 week, because I, frankly speaking, cannot think of any case where I have seen a case like this. And as Lala was also mentioning just now, that it seems to be very rare, even very rarely reported in literature. Uh, if at all it has anecdotally come across somewhere in the clinic, I'm sure a lot of people would think of it as probably a fibrovascular polyp following a vein occlusion or something. Similar to your patient, also literature reports a lot of association with hypertension. So I think that's where people would think, hypertensive patient, you're seeing a vascularized membrane, maybe it's an FVP. They might even see one of the vessel sclerosed patient not willing for FFA, think of laser or something like that also. It can get easily misdiagnosed is what I think. But yeah, but definitely a very rare entity, and kudos to you for an excellent documentation and presenting it to us.
Thank you. Thank you.
So thank you, Manvi, for those nice words. Now I will request Dr. Lala. Uh, Lala, have you come across patients like this before in your practice?
Honestly, I never saw that patient. I also try to read that to understand what is going on, because you sent me in WhatsApp that vascular epiretinal membrane. Uh, I found several cases in the PubMed, several, maybe three or four. All of them mentioning that it's adsodiptotol, this upregulation of VEGF, and they are thinking that it's related with hypertension, as in your case. The only thing which is, I suppose, your case is different from other cases. Yours is location is very strange location. It's other cases is located is superior temporal quadrant, inferior temporal quadrant. Their size is not so big, and your patient is asymptomatic with such huge actually membrane, even without vascularized membrane. It's quite big membrane, and it's located in papillomacular bundle, like in that area. I understand. So honestly, we can you can do publication, and I suppose do some theories what it can be related with ciliaretinal, maybe artery, or maybe not. I don't know. Uh, Angiography, yes, it's okay. I didn't see you. You showed us, yes, OCT angiography, or not sure.
Angiography, we had, I've shown the first photograph.
First
Uh,
photograph.
After
Great.
almost a year, almost around 1 year, 2 months, he was doing the same. Because first time when we saw the patient, when you sent for documentation, then there was a query that whether we are dealing with the right patient is probably telling right, we are noting note. So I was telling my optometrist that probably you have noted wrong. Well, no, no, sir, he's telling, he's complaining of the left eye only. He doesn't have any complaint with the right eye. So, and he's
Uh,
a photographer. So I thought probably he will have some photograph, some issues with the right eye, but he doesn't have any issue in the right eye. So
So
that is
I
one.
think it's you can do very nice publication even in the best journals as a clinical case, because the size is bigger than other publications. I saw the sizes. Even now I checked. Sugnishwari calling my name, but I was looking other articles. Your size is big, and it's located very close in papillary macular bundle. So I think it's very rare case, and the patient asymptomatic. Honestly, what is interesting, of course, in future maybe he will be symptomatic. It's very interesting. When you're planning to do surgery, you mentioned that in discussion, some people did surgery and they're complaining about bleeding, yes, during the surgery. So in your case, one thing is very interesting. It will behave as membrane in proliferative diabetic retinopathy. So it will have some nails like at a severe attachment, or it's not attached at all. That's also interesting actually, but that's for future probably.
Thank you. Thank you.
Yeah, thank you. I think it's very great. The size is amazing, and patient asymptomatic, really great.
so
The
now
limitation is not angiography. That is the limitation. So that is, but even the patient comes, he is not keen to do angiography. So that is one limitation about this presentation.
so my
Only
next
because it's allergic. Yes, that's
He
the
had
reason.
some issues with angiography before. Not sure where he consulted and why angiography was back. Probably because of this, but he's not keen.
That's it's one of the rare cases in the world, so I think it's great. I never had, I never saw. PVR, yes, it can be with vascularized, but epiretinal membrane is really very rare case. Congratulations with your case. I
Thank
hope in
you.
future you will do angiography and you will manage to publish that case. Thank you.
Thank you.
So that's nice comments from you, Lala. And so now I will request Dr. Anupama. Uh, Anupama, what is your thought process about this? See, we all know that this is something very rare, and not many of us would have seen these kind of cases. Of course, like
Yeah.
for instance, like that is, if I have to say, what I have seen in terms of vascularized epiretinal membranes is commonest is in Coats disease. I get to see them very often in Coats disease, and these coats are like the patient does not present at the time of presentation. During the post-treatment phases, with multiple sittings of laser and anti-VEGF, they start developing these membranes, which becomes really thick and it is like a cord almost. So that is what we have encountered, and it's almost sometimes I apparently just yeah, Thursday I had operated on coats, and it was almost like that membrane was we couldn't after peeling it, it has got a stock attachment. See, when you have epiretinal membranes, they are like tangential. When you peel it out, it just comes. You don't have nails like what Allah was telling. So this kind of things, they do have a communication there. Like almost like diabetic, they have one stalk attachment will be there. But these membranes are so fibrotic, and it will be vascular also. It will be very fibrotic. Even a fragmentome was not able to eat away those membranes. It
Okay.
was that much. So almost like foreign body removal, we'll have to remove this, extend the sclerotomy, and all those things. This is what what I have experienced with these thick vascularized membranes in the pediatric age group. So yeah, Anupama, we would love to hear
Yeah,
your
yeah. So
thoughts
I'm
on
not
this.
a surgical person. I'm medical retina. So I see epiretinal membrane, and if it is asymptomatic, I just I follow up the case. But otherwise, if it is symptomatic, I do refer the patient to a vitreoretinal surgeon. Vascularized epiretinal membrane, I have not seen. But with this, of course, I went back to the literature and I kind of looked at the pathogenesis of epiretinal membrane. Thanks to Dr. Suguneshwari, she made me open some articles. So basically, it's because of the micro damage that happens to the ILM. This is the idiopathic because of the PVD, and then you have the Mueller's and macrophages and epiretinal membrane. So I was just curious to know what is the source of these vascularization. Where is it coming from? Is it the retinal vessel? Is it coming from? Like I could not get this answer in the literature. Where is it coming from? And I have another question to ask: will it ever bleed? For example, if I am diagnosed to have something or vessel there, and vision being 6669, and there is always a fear of vision dropping, or is there a possibility that it would bleed? And how often should I follow up this patient?
So actually, these vascularized membranes, one interesting point is when we do an angiogram. See, unlike the other epiretinal membranes, when you do angiogram, there is not much staining into those membranes itself. But these things, they behave like new blood vessels only.
Okay.
Because I have seen some many years back another patient, but it was on a parafoveal telangiectasia. So in that patient, these membranes, they tend to actually fluoresce very much like a neovascularization.
Okay.
But
So
I am not aware whether because see, going by the angiogram, it is leaking over there. So my best belief is either when a PVD induction happens, or yeah, during contraction, it should bleed. That is what theoretically, because I don't know, because none of us have actually come across these kind of cases. Sudipta is the first one to present something like a vascularized membrane, but whether it will bleed and all those things, I don't have an answer for that. Any of the other panelists, Arif or Manvi, do you have any thought process on this, that, or have you come across something like that? A bleeding vascularized epiretinal membrane.
Yeah, not come across something like that, but definitely for the vasculature to grow, there has to be a peg coming from the normal vessel somewhere. I think in Sudipta's case, you could see from the disc there was the idea, the disc, and then in the papillomacular bundle, that lovely membrane coming up. So, why is that? Like Anupama asked, even I couldn't find an answer in literature as to why is that coming out of there. uh, since it seems to be related to hypertension, I was thinking, was there a very subtle minor RVO over there, which somehow led to that proliferation? But then we see so many TRVOs and all, and we don't really see this kind of a thing. So yeah, there is something happening in the pathogenesis. One of the cases which I saw in literature did look like a Mactel or a RAP kind of a lesion, which it seemed to be having. Is that some crossover of something like that happening? Not very sure as to why it happens. Also, again, what I read in literature, when they have peeled, there has been a bleed. So there definitely is vasculature happening there. Why? I don't know. Some hypertension, maybe the hypertension which was like your patient had a lot of copper wiring, silver wiring in the
Yes.
vessels, right? So maybe at some point they had a high uncontrolled hypertension, maybe not known or diagnosed, which led to a microvasculature trauma, budding out from there, and that's where the vasculature grew, and then the fibrosis around you causing this vascularized epiretinal membrane. I don't know if we can prove it. So, but very interesting kind of a pathology, and I got to learn something new and read up about it. And like you said, Sugneshwari, all these coats or even Toxocara and all, where they have these thick membranes which keep forming and becoming thick, and they are extremely difficult to remove intraoperatively. They are adherent to the retina, like almost full thickness. The membrane and the retina is one lesion, and as you said, they're extremely difficult to cut and remove. You endlessly are sitting there and cutting it away. I don't think a frag can cut those membranes. I have also tried that when I have faced something like this. Then given up and finally thought of a frag. At one point, I thought like an IOFB, I'm going to extend my incision and pick it out with a forceps or something. It's
So now I'll request Dr. Arif to kindly give his thought process about this particular rare case, what we are
Sure,
all
ma'am.
discussing about.
Like everybody said, my first answer is the same. Like I have not seen any vascularized ERM in the last 5 years after I left SN. But yes, definitely it's an interesting case, and we also don't know the kind of the source for the vascularized ERM. But I just wanted to comment on the second part of the presentation. The one thing is sure on that, and second part that's well documented symptoms. So one thing I can say is that because of the other eye dominancy, this eye is being ignored much. Patient is not noticing more problem this eye because the left eye you can see such a large double layer sign with the PED and the patient is getting treatment. That is one thing. And if you see the OCT classification of the ERM, he is coming into stage 2, where there is a loss of foveal depression, and you can see the inner layers are getting stretched. So I think Lala or somebody said, if you observe him some more years or so, I'm sure there will be like this Eiffel layer which we'll read in literature, which covers the inner layer, and the patient will start getting symptoms. So since he is in still stage 1 and 2, patient is not experiencing any symptoms, and since the other eye is affected, his whole, and he's also paying for the injections. So his whole idea is about the other eye status. So once this left eye is ignored, so most probably I feel the right eye symptoms may arise. Then we can hear from Sudipto in the coming years, like how did he manage about this case. That's what I can imagine, but definitely an interesting case to be seen. Thank you so much, ma'am.
Thank you, Arif. That was very nice to hear from you. So now my next question will be to the panelist. Anybody can take this question. If at all we have to operate this patient, a day comes. Let's assume that we will all probably agree on this fact that this patient to be taken for surgery only when the patient starts becoming symptomatic, whenever the patient starts having metamorphopsia or the patient is going to have a vision drop. Correct. So I think all of you agree on that point that at this time only we'll probably be taking up a surgery. And if surgery has to be done, would you think that anti-VEGF should be given prior to taking up this patient, or would we want to go ahead without an anti-VEGF? What would be your take on this? Yeah, Sudipta, you can start because since you have seen the patient.
No, I have a query because I see that this vascularization is not in the, because normally what we see new vascularization in the, and we see in OCT A in the VR interface slab. So this vascularization is coming in the superficial capillary slab. So that is one thing I'm little doubtful that even if I try to remove and even if I give anti-VEGF, whether it will be able to regress that vasculature. That is my query, but I'm not sure if the patient becomes symptomatic, whether anti-VEGF, because the patient which is reported in IGO, they had a significant bleeding even after anti-VEGF. So I somehow feel that pathophysiologically, probably this vasculature has something to do with the inner retinal blood vessels rather than the cleavage plane. And if you can see the OCTA also, the flow signals are coming beneath the ERM. So that is one thing I'm little doubtful. I'm not sure that if he at all becomes symptomatic, what to do. There will be probably risk of bleeding. I'm not sure about anti-VEGF. I think I feel that we will probably all give anti-VEGF at least 5-7 days after that. Probably can take up surgery, seeing clinically evaluating, and then decide about removal.
Yeah, Manvi.
yeah, again, like he said, I think we would, in this rare circumstance, want to play it safe and give an anti-VEGF. So whether it will work or not, it's an open debate, but at least we'll give it the benefit of doubt. I just had a thought right now, Subneshwari, I think you might be better. Could it be a hamartoma-like thing? like a chirpy kind of a thing, which we are not. I mean, nobody knows whether they had an evaluation prior to these being picked up, right? And nobody seems to have reported like there was a patient who was normal before and then the ERM grew and became so. Could that be a possibility, Subneshwari?
Yeah, usually in chirpy, like what happens is you're right. So they will have a vascular component, they will have a proliferative component, I mean fibrotic component, and they will also have a melanocytic component. So usually all these things will go together. So that is called combined hematoma. But you can also have a hematoma only involving the neurosensory retina, not involving the RPE. So if that is the situation, you may not have much of pigmentation, but you may still get all these things. But what happens is in that you don't get a that is the glial tissues don't have a proliferation within it, so they don't have an intramural proliferation. They have, what they do is the vascularity of the retina only is very much more engorged, dilated. That is because of the traction exerted by the epiretinal membrane. And invariably these hematomas, they arise in a pediatric, in an infantile age group itself. It's very unlikely that they will grow after that. So the age group is will be very less, and also the vision will be very less, because it will be usually amblyopic at that time, because they get it very early in life. So those, and also to say that they also cause some amount of drill. The neurosensory retina will not be compact and intact because they've been for a very long duration because of the chronicity. Like in Sudipta's case, the neurosensory retina is reasonably good. So I don't expect it to be a hematoma as of now, looking at what the OCT features are, because you can see combined hematoma can be anywhere, peripapillary area, macular area, yeah, little extra foveal. But having said that, it does produce a lot of drill. That component is always there. In this it is missing. That is
There's
what.
also there's also a very good cleavage plane which you can see in the OCT
Ha.
between the epiretinal membrane and the retina. So even that I guess wouldn't be very so
So
obvious in a hematoma.
correct. For him, whatever should be the cause should be related to the something happening close to the disc, because this peripapillary location and anything to do with some kind of an ischemic changes which has happened has only stimulated probably this one. So what has happened to the optic nerve, that is what we don't know. I mean whether he had some kind of insult to, because ischemic optic neuropathy which the patient had, because he's a hypertensive individual. So there are probabilities that he could have had something related to the optic nerve which has caused the proliferation of this one. That is what I mean I can think of, because the area which is so much close to the peripapillary area, so something must be happening at the level of the optic nerve head is what is my best guess. So
So
now,
I think can we add a HDF next time when the patient comes? Because if you're not being able to do angio, an HVF, at least if we have an old insult or some AI predisposing AI when.
yeah, you can check his color vision also, because something
Hmm.
subtle, see, it may not be a florid event, but something subtle, because see his age group also, no, he's not on the very elderly patient.
51.
Yeah, that's what I said. So relatively young patient who is having some kind of a compromise, wherein atherosclerosis is not settled so much. It is more of arteriosclerosis which happens at this age group, very minimal atherosclerosis. So the compensatory mechanisms will work very well in them. So we really don't know what has happened at the level of the optic nerve head itself. So you're, I mean, you can do color vision and all those things, but yeah, angiogram would be
Yeah.
the actual key thing for us to even understand what has happened at that level.
Now, one more thing is that since we are not planning for any surgery as of now, and we are going to prolong it for a long time because we will wait for the retinal thickness to increase, macular pucker to develop, something like this. So usually, when the vessels becomes enlarged or matured, the anti-VEGF may not act that good as compared to the immature vessels. So what I suggest is, if the patient understands and if you can give a trial of anti-VEGF now itself and see what is the response, and but we need to speak to the patient what is the reason we are giving, and to know if the vascularity is going to go down now and the ERM progression will halt and avoids the future need of surgery. So this is definitely depending upon the discussion with the patient, because we don't have a FFA in this case to say it's leaking or not. This is my like one just taking a chance like an Avastin pre-op, or giving now itself an anti-VEGF and wait and watch how the ERM will behave.
No, actually, that is a good thought process also. Only thing is, on the other hand, we must also be prepared for how much of fibrosis we will induce by probably giving an anti-VEGF, because that is another point which we should all think about. If we increase the fibrosis, we will rather be worsening the
Yes, yes.
traction which can happen. I think.
When we were talking to this patient, so because he's so intelligent, he was telling that, as you have already told, that there is a risk of worsening in the left eye, the primary eye, which is being treated with injection, because he's doing good, but PCV some lot of times will not be like that good. So he told that why to do something in the right eye, because you told that left eye also there is a risk, so which was logical from his side.
See, I think an asymptomatic patient is by and large not to be meddled with until he starts complaining, because we also should understand that the risk of any anti-VGF induced endophthalmitis will always be there. Any of these things, iatrogenic complications, we must always be play safe actually. But do you all think that these kind of epiretinal membranes with vascularized membranes, would they have a tendency to produce neovascularization, something like a choroidal neovascularization also? Because there are a couple of reports also stating that patient later on developed a choroidal neovascular membrane.
I also read one or two articles, ma'am, regarding this. They do give injections, and they saw some improvement in the CNVM kind of thing under the ERM. So that was only my concern, like whether they. But since he has done an OCTA, which is not showing any vessels underneath the ERM much, so I was thinking like we wait for some more time for some SRF to develop or something, so the patient will lose little more. I'm telling like patient should not lose definitely, but if something happens, we can have a substantial evidence to start medication for the right.
Yeah, that is, I think that is one good thing about this. And also I would like to know, like when you have a little bit of vasculature to be more, if at all we are planning surgery, what would be the dye that would you would like to use to stain these membranes? Lala, you could take that question. Which dye would you prefer to use if at all we have to operate this patient?
Honestly, I will tell you true. I don't like so much to use dye in epiretinal membrane. Okay, if I am forced, I am trying not to remove ILM if I can, because even the theory behind of all macular surgery is that we should remove the ILM peeling. I'm trying to do nowadays less ILM peeling, even trying to do mostly free ILM flap to take some way ILM, because here, I don't know, maybe I'm lady or not, but the patient is very aggressive. They are demanding, despite of closing macular hole, they are demanding uh, high quality of vision. Here in that case, actually, I have some questions just to clarify for myself. You told that for the left eye, the patient you used ranibizumab because you thought it's IPCV. I'm right or not?
Yes, yes,
And that time in the right eye, you have the same changes, yes?
yes.
Or you saw it later, or you saw that time?
No, right eye was from the presentation only. It was the same.
It was the
Right
same.
eye. Yeah.
So first thing we excluding, it's I have some thought before. Maybe it's related to anti-VEGF when you did injections, because there are some reports that when you are putting anti-VEGF in one eye, in another eye they are getting some tractional retinal detachment, for example, in diabetic patient. So that cause excluding. The other cause, what can be, is hypertensive retinopathy. Maybe you found some new entity. I'm not so sure. I'm not so sure that Subnishra told us may be related to the optic nerve. Why I'm not so sure? Because in other publication, it's very far away from optic nerve. They have that epiretinal membrane vascularized. It's not close to the to the optic nerve. So maybe it's some new entity related to the hypertensive retinopathy, but maybe that is related to choroidal vasculature, as Sugneshwari told before. And what dye I will use? Okay, if I'm not so sure where to peel, here we are using mostly from the Bausch Long. It's like it contains trepan blue and brilliant blue, like brilliant blue, but little bit not brilliant blue, slight modified version, because in 2022, when I came to Chennai, I have some problems with some of my patients because of toxicity, light toxicity. I talk a lot with some of the consultants in SN. I understand that is because of light toxicity, because of constellation. So, for example, nowadays, even using some type of dye here for staining ILM or epiretinal membrane, I am decreasing the light to like practically in darkness in 5 intensity of the light. I am doing full the surgery till the end with 20. So that means slightly dimmed light. And do we need the surgery or not? I am not so sure. If the patient asymptomatic, I don't think so. Little bit I am not so agree with Dr. Mohammed Arif, because I don't think so. We need to put anti-VEGF for the patient which is asymptomatic fully, because it's very high risk, and we are not so sure, as Dr. Manavi told and Dr. Anupama told, that from where that vessel's coming. So I think just to observe and don't think too much about dye. In case if you need dye, of course, any dye is okay. I don't think so. But just think about toxicity. That since 2022, during this type of surgery, I'm more thinking about the light toxicities than anything else. That's all. So maybe it's new really entity for hypertensive retinopathy.
Yeah, that's a good one, Lala. So I would like to request Manvi. Manvi, you're there?
I'm here, absolutely.
Yeah. So yeah, so I would like to know your thought process. Like, okay, leave alone vascularized epiretinal membrane. Let's not talk about that. But if we are talking about in general epiretinal membranes, uh, do you stain the epiretinal membrane all the time, or you don't stain?
No, I don't stain the epiretinal membrane. I only use BBG, brilliant blue green, and I stain the ILM, and I peel the epiretinal membrane as it is. I think most of us do the same.
So, and how often do you peel the ILM in a case of epiretinal membrane?
Almost always. Most of it which is under the epiretinal membrane, so I think any which ways comes off by default, and then you have those tags floating around, so then I do clear that out.
Yes, I think
Contrary
all.
to what Lala said.
No, but actually, nowadays, like this idea of like peeling the ILM, because ILM does, if you peel the ILM, there is a lot of structural defect that occurs. Like for instance, retinal dimpling and all those things. We do see patients have, they don't improve on vision. So, so there is always a debate whether to peel ILM or not to peel ILM. So, I mean, peeling ILM is easy, good for us. We feel happy, but how much does it turn into, improving the patient's vision? But yes, another point is it prevents the recurrence of an epiretinal membrane recurring also. So that is something which we all should remember.
May
And
I interfere for that? May I
yeah,
interfere?
yeah.
So, you are telling recurrence of epiretinal membrane, yes? How will it grow this epiretinal membrane? It will grow mostly like round circle. Do you agree or not? Inside the arcade.
Yeah.
My idea, what I recently, maybe 1 year I started, in all cases, for example, in diabetic patient also, yes, I have before, I was not doing ILM peeling for diabetic patient as a routine surgery. Then I saw some cases, and as you know, in diabetic patient, when you have recurrent detachment, so that cases is much worse to repair than other patient, for example, with PVR and rhegmatogenous retinal detachment. My idea that I am thinking that if it grow in a mostly circular fashion, why not to do ILM just a lot in area which you know where it will grow, like for example 3 dots. That is my idea actually, and doctorate idea. I did PhD, but now I'm doing doctorate. It's different here. So in 3 points in beneath the superior arcade, temporal to the fovea, and temporal macular area actually, and inferior. In 3 dots, I am just removing like 3 dots of ILM. And I am also protecting the central macular area, foveal area, with PFCL. That is my idea. I think it's much better than to remove full ILM, because I'm never seeing the happy patient after removing all the ILM. I have even issue with some patient beginner when I started after SN doing surgery, also happily thinking that when you remove the ILM, it's a great job, or I managed to do very nice surgery. But I think the quality of life of the patient when you are removing, especially foveal and papillomacular bundle area ILM, their quality of life much lower than if you not remove. So my idea to preserve as much ILM as possible, even in the case when we have epiretinal membrane, for example, from diabetes, to just to leave the membrane and to remove in 3 dots, that's ILM. That's my idea. Honestly, I'm doing that research. I'm not so sure to what area I can manage to publish or not. The idea to spare maximum ILM. Even when we are seeing epiretinal membrane, simple idiopathic epiretinal membrane, if in OCT I'm seeing that it's severely attached to the ILM, even a lot of work in PubMed they have. So I think the prognosis will be lower than the patient whose ILM is not fully attached. I don't know, do you mention this when you are talking with patient or not? That attachment of the ILM or not attachment ILM to ARM, how severely attached. If it's loose in some areas, so removing ARM and leaving ILM, it's much better, I think, for prognosis. I don't know how's your expertise about this, but I think more preserve ILM.
Yeah, I think it is a decision which we have to make it case by case basis on how and what we are going to do. A diabetic patient, yes, we understand that sometimes feeling ILM will be better, sometimes it doesn't, it does not. So it depends on, you see, if you have macular edema, you can even do a foveal sparing ILM peel, which helps actually in improving. If you have a patient who's got a recurrent macular edema and you've gone in for some other reason, like for instance, vitreous hemorrhage or something, then I think it is acceptable to remove it. So, but I think it is a case by case basis which one should take a decision about doing this one. So, and I would like to ask one more question, which I'm sure all of us have faced. When we take up a patient for epiretinal membrane removal, the PVD is not going to be that easy, especially if your patient is a hypermetrope. It's going to be really, really a tough call for a PVD induction. So, what do you think that should we be aggressive in doing the, because we all are trained and taught to do so, like to get the PVD beyond your equator up to close to the aura as much as possible. But at times when you see that it is really very strong, do you extend it up to that or do you stop short at equator? What is your call? I want everybody's comments on that.
I induce PVD as much as possible, of course, but yeah, in those cases where it is extremely adherent, as the advancing edge goes ahead, you can see that it tends the retina a
Yes.
bit, and this especially happens in the lower part near the equator. So upper one usually is not so bad as much as the lower half. So I trim it off at that level and leave, because in a case like an ERM or macular hole, you don't want large inferior breaks to be happening. Judiciously, wherever I see that it's tenting, I will stop and trim in those areas. Wherever it's not tenting too much, I will take it further and complete the PVD.
Yeah, I think that that's a very safer call, because otherwise you've taken up a patient for epiretinal membrane removal and then end up putting oil in that patient and then you will never know how much of more epiretinal membrane you'll produce on the patient. So what do you do, Dr. Sudipta?
Only thing what I do separately, actually, when we induce PVD, the initial suction is usually we use more. So if if it is coming very easily, absolutely fine. It's not coming easily, I usually reduce the suction. I don't keep it. Suppose I am doing at 600, I usually reduce to around 350, 400. And with that suction, if it is coming relaxed, absolutely fine. If it is getting hinged at some places, in attached retina, I usually don't bother to remove it further. Usually trim it with slow suction so that I don't create a retinal break in the periphery.
Arif, what do you do?
Same, ma'am. But only thing is that if there is a macular edema case along with that, I'll be extremely careful while inducing PVD over the macular area. So that, like you said, RD, I will create a full thickness macular on table, and then we need to do something else with the PVD also. So, as much as Dr. Manvi said, as much as possible, don't be very harsh. And then if it is a fakey case, be careful about the lens touch also while you are pulling your PVD edges in the peripheral area.
So I think it was really good having a good discussion, the idea of having one case or two cases and then discussing that threadbare, it makes us easy to understand things so well. So I would also like to bring in one more point that I think there are a lot of studies which are coming in, like S1P and all. So like those are because now we understand the metabolism very well. These sphingosine 1 phosphate, which is supposed to be the inducer of or rather the regulator to produce these kind of fibrotic changes, where upregulation happens. So we all understand the pathogenesis is like, this is the PVD. It's an abnormal posterior vitreous adhesion which is there, and these adhesions, they induce this S1P upregulation, and this upregulation produces microperforations in the ILM. Now, once you have microperforations in the ILM, that is when the Muller cells start stretching because of traction, and because of this, now we have the proliferation of epiretinal membrane, and these membranes contract more, and these contraction induces even more denser proliferation. So this is how currently the understanding of this epiretinal membranes are. So, with that, I would like to thank all the panelists who are there here, who have joined, and the presenter, Dr. Sudipta, who was like amazingly brought about one interesting case and made all of us read about vascularized epiretinal membrane for almost 1 week. We've been all trying to find out what is this epiretinal vascularized membrane. So, thank you, Sudipta,
Thank you.
for this very nice, interesting case. And I would like to thank Dr. Manvi, for joining us and sharing her insights with us. Dr. Anupama, who is like, who's busy practicing medical retina with a lot of ROP, still joining us today. And Dr. Lala, I hope you're, the study what you're doing currently on 3 dots, 3 dot ILM peeling and sparing the fovea. So that will be something which we will wait to hear from you in the future. What is your analysis data, so that we probably can try to implement that if it's working well. So whether it works well or doesn't work well, either ways you can tell us, which would be helpful. So all the best for that, and thank you, Arif, for joining us. On this very nice occasion, and it's good to have you here, and it was excellent. So I would like to thank all the panelists and the speaker for being with us, and I will also invite you, for the next power of sessions, which happens every month. We have on the last Friday of every month. So it will be good to have, nice to see all of you together, meeting, rather than meeting in person, we could do this virtual meeting also. So thank you all of you once again. Thanks for all of you joining.
Thank
Bye,
you.
bye,
Thank
bye.
Thanks.
you.
Bye.
Thank you.
Bye. Thank you. Bye.